Welcome to my series of lectures on anesthesiology. Hope you will enjoy this. Now, invasive arterial blood pressure monitoring allows for. Today's topic is invasive arterial blood pressure monitoring. This allows for continuous beat-to-beat monitoring of arterial pressure (BP), displayed as a waveform and provides access for arterial blood sampling. Indications: need for instantaneous analysis of BP, patients with end organ disease, or procedures prone to wide and rapid changes in BP, such as trauma, cardiac, vascular, chest, spine, craniotomies, or monitored hypotension. Procedures with anticipated fluid shifts require multiple blood samples for arterial blood gas analysis may be needed. Long procedures to reduce the risk of non-invasive blood pressure related nerve damage. Mechanics: arterial lines utilize saline-filled tubing which is connected directly into the artery via catheter to transmit the pressure wave to a transducer. Transducers consist of a diaphragm at the base of a plastic dome that converts the pressure change into the arterial pressure tracing. As the diaphragm moves, the silicon crystal is stretched and its resistance changes. This is based upon the strain gauge principle, where the stretching a wire or silicon crystal changes its resistance. In the supine patient, the transducer should be placed at the mid-axillary line, corresponding to the level of the right atrium, and must be readjusted with the patient level adjustments. When the patients are in the sitting position, cerebral pressures can also be determined by placing the transducer at the level of the external auditory meters, which approximates the level of the circle of Willis. The transducer must be zeroed to create a reference point, most commonly to atmospheric pressure. This is accompanied by opening the line to room air via a stopcock. Due to hydrostatic pressures, every 1 centimeter change in the height of the transducer with a 0.75 millimeter mercury pressure difference, thus raising the zero transducer 20 centimeter from the right atrium will lower the systolic and diastolic pressures by 15 millimeter of mercury. The fluid column between the catheter and transducer has no effect on the pressure reading Thus, raising or lowering a patient's arm with a radial catheter will not affect the reading from a stationary transducer. Arterial access sites like radial artery. This is commonly cannulated due to its superficial location and good collateral flow using a 20 or 22 gauge catheter. While 5% of individuals have an incomplete palmar arch, far few patients develop complications from vascular compromise following arterial canulation. The Allen test, Doppler probe, or pulse oximeter are all proposed methods to evaluate collateral flow, although none have been clinically proven to improve the outcome. Brachial artery is large and identifiable. So the brachial artery's proximity to the aorta reduces the waveform distortion. Brachial artery cannulation was traditionally avoided because a hematoma formation or injury could potentially threaten the vascular supply to the entire forearm and risk injury to the adjacent median nerve. Evidence suggests that complications are followed. Brachial artery ablation is lower than previously reported. Now, ultrasound used during placement may reduce the incidence of injury to adjacent structures. Axillary artery. The artery is too much closer to the cerebral circulation, potentially increasing the risk of cerebral embolism during flushing. Femoral artery is prone to pseudoaneurysm and atheroma formation. Aseptic necrosis of femoral head in children is rare but reported. Infection rates are generally higher than the radial cannulations. Other, like dorsal pedis and posterior tibial arteries, form an anatomic arch in the foot analogous to the hand. They are appropriate alternatives in situations of difficult upper extremity access such as trauma or neurosurgery. These arteries are far from the aorta and therefore prone to more distortion. Cannulation technique. Multiple techniques for placement exist and are largely determined by the practitioner. In general, the catheters can be advanced directly off the needle or using the through and through artery technique. Either technique can be performed using a Schellinger technique by fast threading a wire. Now we come to the end of my session. The remaining portion of this subject will be taken up next day. Thank you.